daily users of cannabis were the most represented, while never user participants were most represented in the low cluster. And according to the multinomial logistic regression analysis, as we can see in the forest plot, we found that cannabis users that use cannabis on a daily basis was at a double risk of belonging to the high cluster, but we saw also an increased risk for frequent users and rare or past users. We tested also the model 2, and we saw a bidirectional association. In particular, we saw an elevated risk also for participants who belong to the high cluster to be daily or frequent user. But we we made a comparative analysis of the two models, and we used the McFadden R-square, the deviance, the AIC, and the BIC that were lower for the model 1. And this demonstrated that model 1 was the model with the best fitness and reliability, and it was also the model who better explained the complexity of the data, so that we can conclude that the frequency of cannabis use is the best predictor of cluster membership, and in particular that to a lesser extent, levels of paranoia, anxiety, and depression can predict the use of people. Sorry. We demonstrated that the frequency of cannabis use is the best predictor of psychopathological profile, while the frequency of use, the levels of paranoia, anxiety, and depression predict less the use of cannabis.
Thank you very much.
Thank you. Okay.
And this is a very controversial issue, and I'm going to comment the least I can, because there's a conflict of interest, as you can see from the senior author on this poster. So any questions? Or anybody who believes that using lots of cannabis is good for your anxiety, paranoia, and depression, come out now or never? Mary. Sorry, Professor Canna. Mary, just come here. Mary, if you don't mind, just come here and use this. I think
okay, it's working now, right? Yeah, thanks for this. Really interesting. How did you get a directional approach from cross-sectional survey? Can you explain that? I know you had the past cannabis use. Did you also have past psychopathology?
No, it is a cross-sectional study, and this is the reason why we could use just a multinomial logistic regression analysis, and we had to base our comparison analysis on the index that I showed, but we couldn't analyze prospective data. So that is one of the reasons why we should improve this result with a longitudinal study.
But do you want to explain, Margherita, the model that you use? Why is it something you can use in cross-sectional data to look at bidirectional effects?
Yeah, because basically we found a relative risk ratio of belonging to the high cluster instead of the mild or the low cluster. But since our data are cross-sectional, we couldn't obtain prospective results, prospective findings.
Okay. I can't comment more. Andrea?
From Dr. Haye, if ketamine, I think, to reduce anxiety and depression.
If ketamine can reduce anxiety and depression.
And this is relevant to a poster on cannabis because?
I don't know.
Okay.
Well, I think that if we are speaking about the use of medical ketamine, like esketamine, or for the treatment of acute depression or suicidal ideation, it could improve both anxiety and depression, but if we are thinking of illegal use or drug abuse of ketamine, it may make worse the psychopathological presentation.
And actually, this is a sample that does actually include some people who are using medicinal cannabis. So it's not entirely a recreational cannabis user, because people would know that in UK, now medicinal cannabis, it is legal. And among these, I don't know if, Eduardo, do you remember which percentage are actually using for medicinal reason in our online survey, roughly? 10%, and 10% of this number is now a neglectable proportion. And so it's interesting that, you know, we are seeing people that do believe that actually using cannabis even frequently ameliorate psychological discomfort, including anxiety, depression, but we don't seem to see in this group a reduction in any of these dimension. As you could see, I can't help no comment on it. Anyway, Alex?
So the cannabis users I know tell me that it helps them relax.
It is what, in general, patients say to justify their cannabis use, I think, or from a clinical point of view. But this study demonstrates that also in general population, the chronic cannabis use tend to worsening not only paranoia, but also anxiety and depression, so that there is like a boomerang effect. Maybe you can feel more relaxed when you use cannabis, or you are in the acute intoxication, but after that, probably you will feel some a worse presentation of depression and anxiety. Yes.
Any more questions on ketamine from the online group? No. Okay. So thank you very much, Margherita.
Thank you.
Perfectly on time. This is nothing to do with poster presentation while our colleagues come forward. If you want to know if cannabis is indeed helpful to anxiety and mood, come to the workshop on the Cannabis Clinic, and I will let the data tell you if that's the case.
Hello, I'm Ronan Fleury. I am a third-year PhD with Professor Cannon, and John is also a co-author. He's here taking a very embarrassing photo of me. So I'm looking at adolescent polysubstance use in psychopathology. I started off in my PhD looking at cannabis, and the first paper that we published in the PhD was looking at risk and protective factors for cannabis use. But in the data set that I used, which is the same data set here, I realized that the way that we ask about cannabis use is, have you used cannabis in the past 30 days? To me, that's ambiguous. I'm a psychologist by background. The way you question stuff is very important. And I wasn't asking, have you only used cannabis in the past 30 days? So to me, it needed to be addressed. And when I started to delve into how young people are engaging across Europe, I found that 30% of adolescents are engaging in polysubstance use. But unfortunately, in a review, only 16% of studies actually show data on multi-substance use and mental health. And another review that was done by Lorna Staines, who is also a co-author on this, her review showed that cannabis is identified as a risk factor for psychotic-like experiences, but the data relating cannabis to other substances in combinations such as nicotine is not widely available. So I wanted to delve a little bit more into that. So we used Planet Youth data, which is based on the Icelandic model of substance use prevention. If you're unfamiliar with that, that's basically how the Icelandic government went about it. They do biannual cross-sectional surveys. They look at all of the factors in the environment, such as school engagement, substance use, everything like that, put the research back into government infrastructure, and then they try to reduce down their substance use, which has actually worked really, really well. So Ireland has a similar approach. So in this, we targeted 45 schools. We got 40. In terms of the students, we got an 80% survey response rate, which is extremely good. Our target was 15 to 16-year-olds, so quite young. And we had over 4,000, almost 4,500 students. We used mixed effect statistical regressions on Stata. We did that to account for the fact that these surveys are done in classes in schools across the country, and you can see the yellow bits of Ireland is where the surveys were carried out. Our covariates were gender, ethnicity, socioeconomic status. Our main questions basically were the cross-sectional association between polysubstance use and psychopathology, which I'll get into how we measure that, and then also to explore gender differences. So when we look at the exposure variable, which is substance use the past 30 days, I really spent a lot of time coding on this and looking at how to do this. I didn't want to do a latent class analysis, latent profile analysis, because it doesn't classify everybody in a data set statistically. It's a major flaw with doing something like that. So I drilled down into literally going 1, 0, 1, 0 until I got everything perfect. We have very good substance use within this data set, so it's 2021 data. No use, it's 60%. That's fantastic. But we have individuals who are using any one substance, so that's either nicotine, alcohol, cannabis. So that's 22%, any two, 12%, and then the three, 5%. So they're engaging in all three substances within the past 30 days as well was the time frame that we were looking at. Our outcomes of interest, the strengths and difficulties questionnaire, so we binaried all of these. We had, so the abbreviation is just what I'm calling it, so general psychopathology is what I would call that in terms of an outcome. A score of 20 or over, we're a little bit concerned about it. Psychosis-like symptom scale, a score over 2. The internalizing and the externalizing symptoms, we also had our cutoffs for that. Get into results really quickly. So 50% of those using 2 substances met the criteria for general psychopathology. 51% who were using all 3 substances experienced psychotic-like symptoms. And then again, 45%, 40% who were using 3 substances, so that's the alcohol, cannabis, and nicotine, met the criteria that we would be concerned about internalizing and externalizing symptoms and behaviors. We then went on to our regression models, which was really interesting. You can really see this really nice dose-response relationship where with each single substance that our young people start to engage with, their odds ratios really increase. And I hope you can see the numbers. So for general psychopathology, it's a little over a 5-fold increased odds. For the PEs, so our psychotic experiences, almost 3-fold. And then we got into starting looking at our gender differences, which is really where we saw some striking results. So if you can see the female and the male, I'm just going to take externalizing and I'll take the general psychopathology as well. So with males for general psychopathology, and again, these are 15, 16-year-olds, their odds are almost 4-fold. So that's sort of normal in the literature. You'd sort of see that, especially if they're engaging in harder substances. But the females are almost 8. They're coming up to double. That's huge. And again, for our externalizing, it's almost double. So the main takeaway findings from this is that polysubstance use is significantly associated with a dose-response relationship to psychopathology, but actually it's our female adolescents who are engaging in the same substances at the same rates are really a group that we have to delve into more. They require significant interventions. We need to come up with better ways to examine polysubstance use. I'm very lucky to be in the psychiatry department, so I can ask the psychiatrists how they're looking at polysubstance use, and they're looking at different substances individually and then mapping them themselves rather than having a standardized questionnaire, which actually I think would be very helpful for medical students. The other part of this as well is that staff working in substance use and those working within mental health really have to have the core competencies to be able to deal with both. And that's everything.
And we had a hand up already. Great.
Hello. How did you end up choosing nicotine, alcohol, and cannabis as the...
Yeah, so my PhD is about cannabis, but as I said when I started to drill down into the numbers, we might have 4,400 students in this. None of them were only using cannabis. They were engaging in a lot of other substances, and it got me into this level. And then the thing I wanted to sort of get into the space of what's easily accessible to 15 and 16-year-olds. In Ireland, alcohol, extremely accessible. Cannabis is accessible enough within Ireland for teenagers, especially within some of these rural communities. There can be problems with substance use. And then nicotine, well, it's used so much with cannabis. And also, like 15 and 16-year-olds, if they're going to go out and they're drinking with their friends and stuff, they're more than likely going to have a cigarette, or vaping, which is becoming a massive problem in Ireland especially. So those are the reasons that we included those substances. Easily to get, that's why.
Bronwyn, I was quite curious, and I'll tell you in a moment why. When you look at the 4 groups and the different sort of percentages over the last 30 days, did you have data in terms of how over these 30 days, you know, the addition of the other substance was 1 or twice, but one of the substances was the one that was more the regular everyday use?
Yeah, so we do have data on that. So it's not presented on this,
No,
but there is regular. So the preference, the substance that they were going for the most is alcohol. That was the one that was the point of first to call. That's what they were easy to get hold of. And then after that was the nicotine, then after that was cannabis. But when you started drilled into, so in supplementary materials of this, or we have the data ourselves, I drilled down into what combinations is it? Is it cannabis and nicotine? Is it cannabis and alcohol? Drilled into that quite hard, and actually it's cannabis and nicotine.
Yeah.
Those are the two that are really used very commonly, and then after that it's cannabis and alcohol.
And is this always co-use? Because, you know, like in London, pretty much everybody, I mean, things are slightly changing, but would have a joint with tobacco and cannabis. Yeah. Or do you also have people that on top use cigarettes? Do you know that?
We weren't able to pull that out of the data. It's the limitation of the data, unfortunately. So the way that the Planet Youth Survey works is that Iceland has the survey, and we adapt it to Ireland, but there's core questions that we have to keep in there. And the survey can be quite long, so you have to limit how much they actually do. It has to fit into a 45-minute classroom in terms of data collection. So we're limited by the amount of questions. I would love to ask, if anybody's interested in polysubstance use, there is an amazing researcher called Amanda Bunting. 2024, look up, are you thinking the same way we are about polysubstance use? And she has these amazing questions to put into surveys. The problem is, we only have so much time, you can only ask so many questions, but she's a fabulous researcher to be able to put in questions.
Because it would be interesting how, now that vaping is becoming more common, how much the sort of co-use in youth of tobacco and cannabis will remain, because tobacco is becoming, at least in London, very unpopular, when cannabis is the drug of choice, and that's why many young people are shifting to alternative way of consumption, such as vaping. And you don't see them using cigarette in parallel, you just get them. They vape both. They vape nicotine and they vape cannabis.
The nicotine in this study, I have to say, is the combination of smoking and vaping.
Okay, as well.
So they're grouped into one nicotine. We followed the regulations to be able to do that. Thank God I found a route.
Thank you very much.
No problem.
Were you personally surprised by what kind of findings in this?
I think definitely in terms of the odds ratio for our teenage girls. 100%, I was very surprised at that. Another group that I don't have on here, but the paper is currently in review, so we have it in the paper as well, is our trans group. So our young people who are gender diverse. So that includes transgender, non-binary. And in this group that I don't have up here, they're not engaging in substance use of any kind, which is very different from other countries like the US, like Canada. And I don't know about the UK, possibly, where some people, like we talked about with cannabis earlier, might turn to it to cope, maybe with anxiety or whatever else. Irish, trans, gender diverse are not engaging in substance use in any way, shape or form. So I was very surprised by that.
And our 10 minutes are up. Thank you very much, Ronan. That was great.
Thank you.
And here we have our next poster presenter. And I'm sure the poster is coming up. Thank you for all of you that are staying and asking questions. I really appreciate it, because they, of course, put lots of work in it. So Hamilton, we're all yours.
Thank you, Marta. And I do want to apologize for the ant size text. I think I might have got the aspect ratio wrong, but that's fine. So good afternoon, Palermo. My name is Hamilton Morin. I am a psychiatry trainee at the Maudsley and a doctoral fellow at King's College London. And I want to confess, I'm not a perinatal psychiatrist by background at all, but my motivation to explore this area came from seeing my wife's own experience of hyperemesis during pregnancy and seeing the surprising lack of care pathways in this population, as well as finding several online patient support groups. So hyperemesis gravidarum, or excessive nausea and vomiting in pregnancy, is estimated to affect up to 3.6% of all pregnant women, and it's associated with weight loss, dehydration, and electrolyte disturbances. It's known to be associated with adverse mental health outcomes, including depression, anxiety, and PTSD, as well as neuropsychiatric outcomes like Wernicke's encephalopathy. Of note, over half of all women with hyperemesis consider termination of pregnancy due to the severity of their symptoms. And this, as well as suicidal ideation, are associated with perceived poor care from healthcare providers. So for this study, we aimed to identify relative risks of these outcomes in the first year following diagnosis of hyperemesis. And we also aimed to delineate the relationship between perceived severity of the hyperemesis and psychiatric burden. To do this, we did a retrospective cohort study using the platform TriNetX, which is an international database of electronic patient record data from over 250 million patients over 19 countries. We identified over 476,000 women diagnosed with hyperemesis gravidarum on or after January 2010, and matched them with pregnant controls without hyperemesis by propensity score matching using a greedy nearest neighbor matching algorithm across 17 variables, which includes age, ethnicity, socioeconomic deprivation, psychiatric comorbidities, and medical comorbidities associated with hyperemesis. We then estimated the 12-month incidences of 24 mental health and neuropsychiatric outcomes following diagnosis and compared these using risk ratios. So, for our primary analysis, we found that women with hyperemesis had significantly increased relative risks for most outcomes, including Wernicke's encephalopathy, which you can just about make up at the top, refeeding syndrome, and they had double the risk for any mental, behavioral, or neurodevelopmental disorder. So depression, and specifically postpartum depression, had a risk ratio of 2.7. Affective psychoses had an increased risk ratio, and in particular, puerperal psychosis had a risk ratio of 1.8. Eating disorders, a ratio of 2. Anxiety disorders and a number of other conditions were also raised in risk. We saw also that there was increased risk of prescription of antidepressants and antipsychotics as well. And interestingly, we did a separate analysis breaking down which antipsychotics these were, and it was most typically haloperidol, chlorpromazine, and prochlorperazine, which, as we know, can sometimes be used as kind of a third, fourth-line treatment for hyperemesis. So the majority of these findings were robust to our sensitivity analyses that we did, where we excluded any history of mental, behavioral, or neurodevelopmental disorder in individuals. And postpartum depression still had a risk ratio at 3.3 in this sensitivity analysis, and puerperal psychosis at 1.8. Now, for our secondary analyses, we compared people with severe hyperemesis to people with mild hyperemesis gravidarum. And we saw that there was still increased risk across phobic anxiety disorders, substance misuse, and dissociative and conversion disorders. But what was really interesting was that there was a reduced risk of depression at 0.7 and postpartum depression at 0.7. So trying to make sense of this finding, I asked our expert by lived experience, my wife Yasmin, what she made of this seemingly paradoxical result. And she proposed that this reduction of depression in women with severe hyperemesis with metabolic disturbance may primarily stem from women with a biological marker of severity being more likely to be taken seriously by their healthcare providers, thus prompting better perceived clinical care. So in summary, this is actually, not just in psychiatry, but in obs and gynae, the largest study to date in women with hyperemesis gravidarum. It's the first study to show an increased risk of psychosis in women with hyperemesis. It's of course prone to standard limitations of any study using retrospective patient data. And importantly, the relationship between hyperemesis and severity and psychiatric burden clearly is a complex one and has implications for service development and planning and provision in this historically underserved population. And of course, we need future prospective and mixed method studies to explore this further. So I'd like to thank my collaborators, including Dr. Tom Pollock and Dr. Trudy Sinova-Ratner at the Mother and Baby Unit at the Maudsley. And especially I'd like to thank my wife for inspiring me to explore this area. Thank you.
Perfect timing. And I would like to thank your wife too, because I think that's an amazing study, and for you to actually be inspired by her. And I have a question, but I will see if anybody else has a question first. Okay, while you warm up, Hamilton, do you know in USA, in some USA states, not all of them, which is the recommended treatment of choice for hyperemesis gravidarum?
It's a very good question. I know obviously there's antiemetics, but are you going to say CBT? No, what is it?
Cannabis.
Ah, there we go.
So people would know that cannabis, well, at certain doses, is actually a very effective, well, THC is actually a very effective antiemetic. And now in countries in US where cannabis is legalized medically and recreationally, it is actually recommended for hyperemesis in pregnancy, which is, well, I won't comment. Anyway, any other question? Actually, I have a question for you, Hamilton. Are there any data suggesting, for instance, that women who have one, experiences a first pregnancy, they will have hyperemesis when they have other children, or they're put off for life from having other children, so you don't have such data?
So, I mean, in terms of obstetric studies, we know that previous hyperemesis is, of course, a risk
predictor,
factor for the future. And there's a number of other risk factors, including kind of female pregnancy, also nulliparity if it's your first one, but interestingly, multiparity if you've had several pregnancies. Socioeconomic deprivation is actually associated with less likelihood of hyperemesis gravidarum, which is interesting.
Do you think it's to do with age of the mother, or no, there's nothing?
It's entirely possible, isn't it? I think if we look at kind of Western developed countries where age of pregnancy tends to be later.
Shifted later.
But I should note that historically, there was this misconception that it was all conversion, that it was all somatization in the 60s and 80s. But of course, last year there was a great Nature paper that found GDF15 actually is clearly linked to increased kind of a genetic risk of hyperemesis gravidarum.
Very interesting. Mary, Professor Cannon.
Hi, thank you very much. Just two questions. One is, I would have thought that the antipsychotics were pretty much always being used as an antiemetic agent in this. Can you figure out whether that was the case? Secondly, it's really concerning that these women are developing Wernicke's encephalopathy. Is there a delay in treating them, or medic's not right? This is actually a physical health complication, isn't it? Not really mental health or neuropsychiatry. Why do you think that is happening in this day and age?
So I do want to emphasize that, yes, for comparison of hyperemesis with healthy pregnant controls, there is an increased risk, but obviously the confidence interval is very broad, as you can see in that top line in that figure. And so even though there is this increased risk, it still is very rare. But obviously Wernicke's we would associate with the picture of the chronic alcoholic coming in. So perhaps people are lowering their guard and not suspecting it in these otherwise healthy pregnant women when it emerges. Yeah. And in terms of the sub-analyses for the reason for the use of the antipsychotics, within this specific platform, it's difficult to delineate that without some quite intricate sub-analyses. But I think given the antipsychotics that are being used more do tend to be the ones that are associated with hyperemesis, I would agree it's most likely that they're being used for that indication more so than psychotic disorders.
Thank you very much, Hamilton. That was great. Poster up. But more worryingly, I don't see Ruprai. Where is Ruprai? Oh, hi. Oh, Richard, sorry, you are misleading me. So you are the second author. So sorry. Apologies,
Sorry.
Richard. Let me reset my, yes, ready, all yours.
Thank you. Thanks for choosing this poster, the presentation, and thank you for staying into the twilight shift. My name is Richard Summers. I'm presenting on behalf of Dr. Ninesh Ruprai at the University of Birmingham. We've been conducting a validation study in women's centres across the UK, and they provide support and services to women who are involved with or at risk of being involved with the criminal justice system in the UK. And our preliminary findings showed that actually there was a surprisingly high number of violent crimes amongst these women. So after some conversations with caseworkers and with the individuals, what we found was that there was a high correlation between domestic abuse situations and assault of a police officer. So what we can sort of take from that, police have been called to a domestic violence situation. The woman ends up by lashing out at the police officer, who then gets arrested for assaulting a police officer. And so this is obviously, through some other conversations, we've also found that these women have reacted sort of with hostility to help. And so we started to consider complex PTSD as a potential explanation for this. Because of the emotional dysregulation, negative self-perception, and the relationship difficulties, and including problems trusting others, it's currently in the ICD-11, but not in the DSM. But as part of this, we aimed to explore the prevalence of complex PTSD in this cohort as measured by the International Trauma Questionnaire. So when the women arrive at the women's centers, they are given a comprehensive holistic assessment, which we were validating at the time. It contains quite a few subscales like substance abuse, history of abuse, employment, financial difficulties, and so on. And we supported the caseworkers to also utilize the International Trauma Questionnaire as part of that assessment. So we ended up by collecting data for 94 women with a mean age of 36 who are predominantly white. And what we found from the results section in the middle, we can see that there's a high prevalence of traumatic experiences. So from figure A, you can see that 61% of these women had been homeless, 62% of the mothers had had their children taken away from them, 57% had experienced childhood physical abuse, and the list goes on. And from figure B, this is a result. This is our correlations from our validated Werner assessment, which shows that actually these needs are quite well correlated. And we found that actually 82% of these women met the diagnostic criteria for complex PTSD. It's important to say that we're not clinicians, so we say we're not diagnosing anyone, just that they met the diagnostic criteria. And so the risk factors for this included in figure A showed that from the odds ratio of the univariate binary logistic regressions in the yellow, that women who had been homeless were 6 times more likely to meet the criteria for CPTSD, the removal of children 3 times more likely, those who'd experienced childhood abuse 3 times more likely, and those who had had history as a child who had been put into residential care or a youth offending facility were 6.5 times more likely to meet that criteria. And so you can see from the orange, which the elastic net regression shows that prison is also a risk factor here. So what this means for us is that these patterns align seemingly quite well with the patterns of complex PTSD. And many of these observed behaviors in women in the criminal justice system are explained through this lens. And I think because of the interpersonal traumas that lots of these women have faced, this has led to sort of mistrust, avoidance, and using anger to remain safe. And it's these behaviors that hinder the service engagement and intervention efficacy. And these women, because they're already involved in the criminal justice system, everything about them is viewed through a lens of risk, particularly criminogenic risk. And to quote Dr. Datali from earlier on, that complex situations require multidisciplinary interventions. And so we need to have better multidisciplinary support for these complex needs to make sure that these women don't fall down the gaps of services. And also better de-escalation techniques are needed to the police that turn up who are aware of women who are involved in domestic violence situations.
Great timekeeping. Richard, thank you very much. Any questions? I have to ask one question. I see in this very comprehensive list of predictors, there is one missing. Any cannabis use or substance misuse?
Actually, so substance abuse is quite high up in terms of the criminogenic risk. But actually, because we had a very unbalanced data set, we had to run this funky regression to kind of explain what was going on. So the 82% met the criteria for CPTSD, so we had to make some adjustments for that. But obviously, with the low sample size, we weren't able to explore that in as much detail as we'd have liked to have done. Certainly, there's a high proportion of women who have substance abuse issues, but because this is done at the baseline, a lot of these women come into the center on probation contracts, and if they disclose substance abuse to their probation officer, they go back to prison, whereas the kind of conversations that they can have with their caseworker in the women's centers is, I only smoke a joint on the weekend now, whereas I was taking heroin 6 months ago. And that's celebrated in the women's centers, and they try and keep as much of that away from the, as much as possible from the probation workers to kind of support them through that, through the journey of celebrating small wins, but also kind of saying, you're still breaking the law. If you get caught, you're going back to prison. So
I think that's very interesting, because I was actually wondering if you find something similar to what Ronan found, you know, in when he looked at the teenagers with polysubstance misuse, and he found sort of stronger effects in different dimension when he looks at the sort of female group. That's why I was wondering what role played substance misuse in your court, but I appreciate that disclosing it has different implications that do it in on a survey. Diego.
Just a comment on that. It's probably true that in the criminal justice system, as you said, the proportion of substance use is so high that there would be very little variance to explore it as a predictor. I mean, this is just a guess, but it's probably very, very high proportion.
Could also be that, yeah.
Thank you, sorry. Just a comment, because it's very, we know that child abuse are linked to PTSD, but what we found more recently that such as homelessness, it's a factor in itself which is not very intuitive, and it's very interesting to point it.
Yeah, so about that, so it doesn't really appear anywhere in the lists of triggers or criteria for complex PTSD or PTSD. So there's a bit of gatekeeping going on as to what kinds of traumatic experiences count as traumatic experiences. But for this, I think it was quite difficult, as you say, is it's a little bit complicated to disentangle that, because homelessness we know is a traumatic event. I can't imagine being homeless and how traumatic that is, but it's also a culmination of lots of other things gone wrong. So there's lots of things at play that land to that situation, which is probably why it's such a strong predictor.
Effect.
And the same with custody, the removal of their children. You know, a lot has to go wrong to get to that point.
And
can you tell us a little bit about the Women, Crime and Justice Research Team? Like, what's the team made up of? What sort of disciplines? What do you do?
So our research team is based at University of Birmingham, and we are in the social policy department. And we are taking this from a social policy angle. So we're sort of quite aligned with critical criminology and really looking at the traumas of women in the criminal justice system. So there's a couple of work streams that we are doing, which is making sure that we are gathering evidence for trauma-informed approaches, diversions away from prison. So we are sort of trying to gather enough evidence to suggest that this is a good way to go. So we don't send people to prison, they go to court, they get diverted to services instead. And through that, we're supporting the Effective Women's Centre project, which is sort of looking at their efficacy in the sector as well. So.
Thank you very much, Richard. That was great. And thank you for contributing with all the questions. And last but not least, a fellow Sicilian who has migrated, nevertheless, a very long way away. Ettore, we're all yours.
Thank you, everyone, for giving us an opportunity to present this joint work that we did, myself and Naomi. So we joined basically Australia and UK in something that is mostly an area of that we know is particularly consistent in all the delivery of service, especially for young people. Basically what we did, we look at what actually we are dealing and how service in youth mental health and in child and adolescent mental health are responding to the demand for more complex clients that are coming to our services. So basically what we did, we look at the adaptation and how we can provide a more service that is able to provide a more appropriate competence. And we look at specifically data in Australia, but also in UK. And you want to add something, Remy?
Yeah, sure. So I am a PhD student from the University of Warwick and also a clinical lead in the NHS, specifically for children and young people with neurodevelopmental differences and co-occurring mental health conditions as well. And so when I met Ettore, we basically discussed very quickly our joint interest in looking at those with neurodevelopmental conditions, but also with co-occurring mental health. And I had surveyed clinician knowledge, confidence, and the approaches used when delivering psychological therapies to these populations, those who were autistic, had ADHD, and also those with learning disability as well. And this is based on the studies that were also done in the USA and a Canadian study as well. So it's got a global perspective, and Ettore also did a similar study in Australia.
So we did a quality improvement project in Australia where basically we looked at all the client attending our different clinics, and we found out that the average is 37 to 70% of people presenting a co-occurring neurodevelopmental condition. And therefore, obviously, we identify what are the barriers. The barriers obviously are in clinician training, opportunity for also to navigate the system. So, for example, we identify in Australia we have something called NDIS, that is the National Disability Insurance Scheme, that is quite challenging and complex. So identifying specifically navigator who will support our client. But more important is how do we improve the overall knowledge and clinician training, and that's where we are working towards an integrated project with Naomi.
Yeah, so we've decided that one of the main gaps that we found in all of our studies really, and from a global perspective, was that there's a transition between aged 18 plus services. So children and young people, as soon as they reach the age of 18, there's kind of like a transition cliff. They don't actually move into adult mental health services so smoothly. And so this is something that we would like to work on. So I'll be traveling to Australia as well to look at kind of what we can do there, but also what we can do in the UK to bridge that gap as well, and also provide the recommendations around adaptations to psychological therapies that do work and are evidence-based, as well as generally improving the knowledge and the confidence and the skills of those psychotherapists, the psychological therapists that are already working within mental health services.
So bottom line, this review of the two services really highlight the lost in transition problem that is very common in many services around the world, and not only in our two services. And we identify probably the best outcome will be to increase knowledge, to increase the training, but also to develop a practice that are more user-friendly and are more attuned. So basically, as I always say, these clients are already with us. We have to improve the way we respond to them, and how to improve is basically changing the mentality, the training, and the opportunity for them to be supported in our services.
Yeah, I would love to, hear from you really. Yeah.
Thank you very much. I'm perfectly on time. So, Naomi, you mentioned the issue of transition from sort of child and adolescent services to sort of adult services. In UK, it works quite nicely if you also have psychosis. So say you have a neurodevelopmental diagnosis and also you have psychosis. Most of child and adolescent services have a transition care coordinator that works in both. So, and I know this because I work in an early intervention for adults, and I work with this transition care coordinator, and I tend to get most of the young people that become 18. But one of the problems we do get is that when they also have a neurodevelopmental diagnosis and they come to us, we have no idea how to adapt our language, our intervention to their needs. So we're fine with the psychosis, but we're not fine with the neurodevelopmental component. And to make referral to the ASD adult service means that they get seen in 3 years' time once they've been discharged from the early intervention service. So I was wondering, because I know you talked about training, if you were thinking about models where whoever gets this population when they become adult, rather than entirely relying on specialist service, we can at least give sort of a decent model of care, even if we're not specialist on, say, ASD or, I don't know, actually, what I mean, you do in Australia.
Exactly, that's my goal, actually, Marta. This is what we are trying to do, because obviously we are in a similar situation, because youth mental health service that is peculiar of Australia, I guess there are some other services. So we serve the 16 to 24, and we already have challenge because most of the clinicians, these clients are already with us. So what we want to do is basically to develop a specific training for our clinician to work with them, because it's, as I say, it's everyone business.
No,
and,
exactly.
And definitely we don't want to have a more specialist service. This should be considering the number, because as I said, prevalence goes through a minimum of 37% to 70% in our youth cohort of clients. And the presence of ADHD, ASD, specific learning disorder, all of that really pose a challenge also, because they don't get better, they get to use substances more than others. That's the other common problem. They have a criminal justice issue. And when they are in an inpatient unit, their length of stay is longer and longer because they don't get easily discharged. So my advice is that what we are trying to do in Perth is we are trying to develop a neurodevelopmental stream that should be integrated. It's still a big challenge because most of our adult colleagues feel that they don't have the knowledge. We offer the training. We are happy to upskill them. But again, that's watch this space. I hope I can present next year something better.
Well, that's very good already, but we'd be delighted to. Robbie, you good?
So I notice you say there are 13 million neurodivergent people in England, and I wondered what proportion of these people require any intervention, or what proportion should we just say that, well, they are just a normal variant and let them get on with life?
Yeah, so thank you for that question. So that was globally, that stat, 700,000 in the UK. And 3% of those children and young people actually access a service at the moment. So that's the level of need. As you all are probably aware, that sounds quite low. And part of my PhD is around looking at the barriers to accessing services in the first place. So a lot of our children and young people are not actually even able to access the service in the first place. And as you'll see from the PPI comments on there as well, we've had parents with lived experience of children and young people themselves explain that they are having to refer and only being accepted after the 4th referral into a mental health service at its earliest possible stage of needing support or an intervention for a mental health condition, and this sometimes can be where we then see these children and young people left with untreated mental health conditions that then need later on inpatient support and services.
So the 3%.
So you're saying that the level, we don't even understand the true level of need because the children can't actually get diagnosed because of the waiting lists?
This is it. So it's because of the waiting list, and also what you may be aware of, which is diagnostic overshadowing. So it may be that they have a diagnosis of, ADHD or autism, and that kind of overshadows the mental health condition. So every behaviour or concern that has been given in terms of whether it's challenging behaviour or self-harm or hearing voices. A lot of the time in clinical practice, parents, carers and professionals are advised that that is attributed to autism or that is attributed to ADHD, and so the mental condition is actually not treated at all or is lost in that.
And I can add that in our cohort, that is, are the older kids, actually these are clients who are referred to us for a mental health condition, for severe anxiety, severe or psychotic disorder or emerging psychosis or borderline personality, and then they are actually at a better overview, they are positive to a sort, at least one or more neurodevelopmental disorder. So basically the elephant is in the room. What do we do with that? How do we improve our delivery of services?
Thank you very much. That was great. Well, you'd be pleased to know there are not going to be more cakes, no more coffee, and no more sessions, so you're free to go and enjoy in the sunshine Palermo. And the votation for the poster and lunchtime on Wednesday, because the winner will be announced in the afternoon and they will get the prize at the aperitif. So you can start, you can think about it. And if you want to remind yourself about the wonderful sixth poster you had of this afternoon, you can go on the website of the forum that you all know because you use it to register. And there is a folder that says poster where you can view all the poster and the six that were presented today. So do people know where the venue is tomorrow? Can people tell me if they think it's in this same place? Put a hand up, same place. Good, you all passed the cognitive test. It's not here, don't come here tomorrow. Look at the email I sent you, it's across the road on the right-hand side, walking towards the cathedral, and you'll see a banner outside. Have a lovely evening and thank you for staying so long.